Bismillahirrahmanirrahim. Assalamu alaikum dear students. Now today we are going to start second part of our topic opioid analgesics. I'm Dr. Neelofar Yousaf. So yesterday we discussed about opioids, their origin, how they are extracted. Then we discussed about very important drug morphine, and we discussed about pethidine. Now today we are going to study about methadone and other similar chemical structure drugs. Methadone. It is chemically dissimilar but similar in most of pharmacological actions to other opioid drugs such as analgesic, respiratory, depression and other effects. They are they can be taken orally as well as parenterally, and they are effective both ways. Single dose effect is same with morphine, including duration of action. On repeated administration, its effect is added. Half-life is 24 to 36 hours. It is highly bound to plasma proteins, which is 80 to 90%. It is also metabolized by liver by demethylation and cyclization. It is also excreted in urine like other group members. Slow action and less subjective effect. Abuse potential is low in comparison to other drugs. So we can prefer this drug on morphine or other which have potential of abuse. Used as substitution therapy as opioid dependence. Codeine is used as substitution in methadone addiction. If a person got methadone addiction, then it can be replaced by codeine. Then comes tramadol. It is used for excruciating pains and it is also very much in practice, daily practice. So it is centrally acting analgesic, very strong, potent effect. Very low action on opioid receptors. Other mechanisms involved in analgesic action are serotonin and noradrenaline or norepinephrine reuptake inhibition. Inhibits pain at spinal level. Effective both orally and IV. Side effects are similar to those of morphine but less prominent. It is well tolerated and abuse potential is also low. Only partially reversed by naloxone. So this is the perfect antidote for morphine poisoning is naloxone. Used in chronic neuropathic pain and short diagnostic procedures. Its dose is 50 to 100 milligram, can be given IM or IV oral. Now very important opioid receptors. ठीक है जी, इसका क्वेश्चन आता है ये इंडिविजुअल ड्रग्स के अकॉर्डिंगली भी आ सकता है या सिर्फ रिसेप्टर्स का भी पूछा जा सकता है एंड यू हैव टू राइट in tabulated form. I'm telling about today's assignment. You have to write down in tabulated form all three type receptors of opioid receptors and their location and their subsequent actions and the kind of peptide it releases. So mainly three types of receptors: mu, kappa, and delta. Subtypes are mu 1, 2, kappa 1, 2, kappa 3, delta 1, and delta 2. They are located at peripheral nerve endings, in spinal cord, in midbrain, and brainstem. Opioids can act as agonist, partial agonist, or competitive antagonist of these receptors. So basically, these are opioid receptors on which opioids will act or naturally releasing physiological neurotransmitters such as peptides that act on them. ठीक है, तो you have to write about opioid peptides too, which opioid peptides are going to act on these receptors in tabulated form. Overall effect depends upon nature of interaction and affinity of these. Morphine is agonist of all but affinities had for mu. Morphine is agonist for all these receptors, but they have most affinity for mu receptors. Mu 1, mu. This is a table which is very important. Location, mu receptors are mostly present at level of supraspinal, spinal. Then comes kappa receptor. They are present. They are also present at spinal and supraspinal. K1 at spinal and K3 at supraspinal. And delta are present equally distributed on spinal and supraspinal levels. So mu receptors are responsible for following effects such as analgesia, respiratory depression, sedation, euphoria, meiosis, physical dependence, and loss of gastrointestinal GI motility. Agonists on these receptors are true agonists such as morphine, codeine, fentanyl, and pentazocine Vs. On kappa receptors, effects are such as spinal analgesia, dysphoria, sedation, psychomimetic physical dependence, and agonist on kappa receptor is pentazocine. Now comes delta receptor. They are at spinal and supraspinal sites locations, and the effects are such as spinal analgesia, effective behavior such as जिसमें हमने पढ़ा था कि जी perception interpretation of पेन ही ऑल्टर हो जाता है, एप्रीहेंशन होता है, फेयर होता है, उसको इफेक्ट करेगी. ठीक है. स्पाइनल इफेक्ट्स में फिर रेस्पिरेटरी डिप्रेशन, रिड्यूस्ड GI मोटिलिटी आ जाएगी. So effects of opioid receptor stimulation. If mu receptors on peripheral afferent nerves are stimulated, then what will happen? They will inhibit the release of pain-promoting neurotransmitters such as substance P and bradykinin. If mu receptors in spinothalamic tract are inhibited, what will happen? Inhibitory postsynaptic potential on neurons carrying pain input to brain. If receptors in midbrain are inhibited, what will they will do? They will act as excitatory postsynaptic potential in descending inhibitory pain pathways. On spinothalamic tract, they are acting as reaction, whereas in midbrain, on new receptors, opioid will have excitatory action. So, mu receptor related opioid analgesia limited to perception of nociceptor stimuli, no ceiling effect, effective for the relief of nociceptive and neuropathic pain, both developmental tolerance and physical dependence है. अगर फिजिकल डिपेंडेंस होती है तो इसमें क्या होना चाहिए? हम कॉम्बिनेशन दे सकते हैं प्योरली म्यू एंटागनिस्ट का, पार्शियल एगोनिस्ट का. ठीक है. या हम चेंज कर सकते हैं, एक ओपियोइड से दूसरे ओपियोइड में जंप कर जाएंगे ताकि हमारे पास रेजिस्टेंस डेवलप ना हो, टॉलरेंस डेवलप ना हो. रेजिस्टेंस सॉरी बाद में फिर ग्रुप रेजिस्टेंस आ जाती है, मगर टॉलरेंस डेवलप ना हो तो हम चेंज करते रहेंगे, घूमते रहेंगे एक से दूसरे, दूसरे से तीसरे ओपियोइड पे. Opioid receptors, and how do they act? They are actually, what is their intracellular mechanism of action? All are G protein coupled receptors. They are located on prejunctional neurons. They inhibit release of transmitters such as noradrenaline, dopamine, serotonin, GABA, and glutamate. Here is your assignment question. Write the mechanism of action of opioids. ठीक है. Activation reduces intracellular CMP formation, opening of potassium channels via mu and delta, and suppression of N type of calcium channels. Basically, what happens? I'm telling in you simple language. This was calcium channels. ठीक है. Calcium channels block होंगे तो क्या होगा? CMP वगैरह डिक्रीज होगा, जी प्रोटीन कपल्ड होता है, ये क्या होगा? इन दैट ये सारे न्यूरोट्रांसमीटर्स की जो रिलीज है उसको इनहिबिट कर देंगे. ये चीज़ें कॉज कर रही थी. ठीक है. न्यूरोट्रांसमीटर्स को ये ब्लॉक कर देंगे. समझ आ रही है? जो कैल्शियम से रिलेटेड जिनकी रिलीज थी. दूसरा क्या करेंगे? ये इंट्रासेल्युलरली क्या करेंगे? सीएमपी की फॉर्मेशन को भी रिड्यूस कर देंगे. क्या होगा, पोटेशियम ओपनिंग ऑफ पोटेशियम चैनल हो जाएगी, जिसकी वजह से सेल क्या होगा, हाइपरपोलराइज हो जाएगा. Okay, now moving next. Ultimately, hyperpolarization and reduced intracellular calcium reduce neurotransmitter release. I'm repeating this slide so you can recall what I just said. All are G protein coupled receptors. They are located on prejunctional neurons. Inhibits release of transmitters such as noradrenaline, dopamine, serotonin, GABA, and glutamate. Activation reduces intracellular CMP formation, opening of potassium channel via mu and kappa, and suppression of N type of calcium channels, ultimately leading to hyperpolarization and reduced intracellular calcium, which further reduces neurotransmitter release. There are various endogenous opioid peptides present in our body which are released physiological under different physiological conditions. अब ये opioid peptides क्या करती हैं, ये opioid receptors में जाके उनको stimulate करते हैं या opioid like effects को produce करते हैं, such as endorphins, enkephalins, norphins. So endorphins are derived from POMC. There are beta endorphins. These are of two types, 1 and 2. They act primarily on mu receptors as agonist, and it has kappa action too. Then comes enkephalins. They are derived from proenkephalin. Two different types are met enkephalins and leukenkephalins. They are primarily acting as agonist on mu and kappa receptors, whereas enkephalins act as only kappa agonist. Dynorphins derived from prodynorphin, two types A and B. They are potent kappa agonists and also have mu and delta. Sorry, here I have said instead of delta action of endorphins and enkephalins. Here as we have noticed that dynorphins are having kappa agonist, potent kappa agonist action, where it also has mu and delta actions. Analyze the antidote on naloxone, which is very important and very important MCQ question. So coming back to nalorphine, the drawbacks are dysphoria and psychomimetic. Then comes pentazocine, weak mu receptor antagonist but agonist of kappa receptor. We are discussing about mixed types, which are agonist or antagonist mixed types. On one receptor it is agonist, on other receptor it is acting as antagonist. One of the commonly used agents given orally and IM, low abuse liability. Uses are they are used in moderatory severe pain, in injuries, burns, fracture, trauma, cancer, and some of the orthopedic. What is the difference between pentazocine versus morphine? Spinal anesthesia via kappa receptor. We can use it as analgesia and they cause analgesic effects via kappa receptors. Sedation and respiratory depression at low doses. There is tachycardia and rise in blood pressure, so it is very dangerous in MI, myocardial infarction patients. It causes spasms but lesser smooth muscle spasms. Vomiting and other side effects are also less with pentazocine. Subjective effects are such as lower ceiling effect. Tolerance develops upon repeated use but lesser than morphine. There are also withdrawal symptoms. Good analgesic in subjects not exposed to morphine. They also precipitate withdrawal such as in morphine addicts. Buprenorphine. Synthetic thebaine, collagen and highly lipid soluble drug. It is selectively mu agonist analgesia. 20 to 30 times it is more potent than morphine. Slow but longer duration of action up to 24 hours. Pharmacological effects are similar to those of morphine has high ceiling effect and analgesic and respiratory depression. It is a good analgesic for naive patients by addicts precipitate withdrawal syndrome. Low tolerance and physical dependence in morphine and reduced liability. Withdrawal syndromes are similar to morphine. So they belong to same group with little slight differences. So you should know about highlight these slight differences. Adverse effects related to buprenorphine are hypertension, postural hypertension, respiratory depression, which is fatal in neonates and cannot be reversed by naloxone. Uses are long-lasting painful conditions such as cancer, post-operative pain, MI. Previously, we said that pentazocine is not used in MI patients. So, preparations are such as morphine and digesic. Now comes naloxone. It is competitive antagonist of all types of opioid receptors but block mu receptors at much lower doses. It is always injected intravenously. All symptoms of morphine action are antagonized, especially respiratory stimulation. At high doses, antagonizes actions of nalorphine and pentazocine, such as dysmorphic and psychomimetic effects are not suppressed. Buprenorphine actions are prevented but not reversed fully because they are tightly bound with receptors. Also act on endogenous opioids, antagonizes respiratory depression of diazepam and N2O. They are used in acute morphine poisoning, in neonatals, newborn opioid poisoning, reverse respiratory depression intraoperatively. It is also used for diagnosis of morphine addiction, and it is also used for alcohol intoxication. So sedation हो गया, एनाल्जेसिक इफेक्ट हो गया, रेस्पिरेटरी डिप्रेशन हो गया, इसके अलावा opioids के other uses क्या, let's discuss about them. Yesterday I told you about it causes constipation, so we are also using it as antidiarrheal agent, especially drugs antiphenoxylate and loperamide. Then we discussed codeine is not too dangerous to suppress cough reflux, so it is also used as antitussive. So important questions related to opioids are classification of opioids. Remember pharmacological actions, adverse effects, indications and contraindications of morphine, pethidine and pentazocine are very important. So in short, you have to remember each and everything in this chapter, especially opioid receptors, morphine toxicity, and slight differences of other group members from morphine. Which drug does not activate opioid receptors has been proposed as a maintenance drug in treatment programs for opioid addicts, and with a single oral dose will block the effects of injected heroin for up to 8 hours. So what would be the answer? Amphetamine, buprenorphine, naloxone, naltrexone. We have talked about it. Propoxyphene. Think over it. Okay, let's go to the opioid antagonist naltrexone has a much longer half-life than naloxone, and its effects may last for 2 days. A high degree of client compliance will be required for naltrexone to be of value in opioid dependence treatment programs. The same reservation is applicable to the use of naltrexone in alcoholism. So the answer is